For next talk, I would like to call upon Professor Bilal Hameed. He will be talking about complications of acute liver failure, riding out the storm. Sorry, sir, I kept your intro very brief as per your say. He's professor of medicine at UCSF and principal investigator for NIH-funded acute failure study group. Sir, please.
Assalamualaikum everyone. Thank you, chairpersons. Thank you, Dr. Zuberi, for the kind introduction for acute liver failure. There will be some repetition of what Dr. Zuberi has mentioned, but my job is to discuss about what acute liver failure is and complication and management. The important thing is that for the trainees and for most of us, as a transplant hepatologist, when the patient with acute liver failure comes in, these are one of the sickest patients we have in our ICU. Luckily, at our institute, we have an open ICU, so as a hepatologist, we manage these patients with the intensivists, but we are the primary care on those patients. So the topic is that literally when these patient comes in, when I get a call, this acute liver failure patient comes in, we have everyone ready. With Dr. Superi has mentioned, all the specialists are ready because these patients can get really sick very quickly, and you need to do many things at the same time. You need to talk about the diagnosis, management, and thinking about whether they need a transplant. So you have to have everyone together making those decisions. But I wanted to talk with the case first. So this is a 22-year-old patient who was admitted with confusion and jaundice to our hospital. No history of alcohol, IV drug use, prior history of liver disease, family history of hepatitis B, but never had checked or any had testing for hepatitis B. On examination, patient was jaundice, had confusion with asterixis, and was intubated in the emergency room. His bilirubin was 15, ALT was 1200, AST 900, INR was 3.4, and also had acute kidney injury with a creatinine of 2.5, and then hepatitis B surface antigen was positive. So the question is, what is his prognosis? Now, this patient is in your hospital. How this patient will gonna do with this acute liver failure for hepatitis B? And chance of him getting better without a transplant, because that's the most important discussion that we have, that how quickly, if they are in a hospital, does not offer transplantation. And that's the first teaching for us, when we talk to our physician outside, that all these patients with acute liver failure should be considered, talk to a transplant center, whether that patient need to be transferred. I know the resources in Pakistan are not there, therefore we will talk about the management, at least that how we have. But it's important for trainees to understand not to confuse this with acute on chronic liver failure. This is acute liver failure, which is the presence of coagulopathy with encephalopathy in someone who does not have any pre-existing liver disease. There are some exceptions with Wilson's disease and autoimmune hepatitis, and if someone has hepatitis B, ideally the INR is greater than 1.5 and duration of illness is less than 26 weeks. So this is a common thing that people get confused. They label it, and we don't consider acute alcoholic hepatitis right now with acute liver failure. And also the timing is somewhat important, although you don't, but in hyperacute, these are mostly patients with acetaminophen or paracetamol, that they come really sick less than 7 days after development of jaundice. And then subacute, we have seen in like hepatitis B, autoimmune, and some of the medication that onset of hepatic encephalopathy was greater than 5 weeks, but less than 12 weeks after the development of jaundice. Now, this is one of the most severe injury. And in America, we think there are 2,000 cases per year. Early on, before we had liver transplant or better ICU, the survival was really poor. It is very fascinating, but very frustrating, very hard to treat, and also very difficult to study. So I was lucky to be a principal investigator for this acute liver failure study group with Dr. Will Lee started. So when I joined UCSF, I was for 10 years and principal investigator. And a lot of data in the US was collected from that study and which was shown. But this is, there are many causes of it, and this is not a complete list of it. But, the point is when you develop acute liver failure, it does not matter what the causes, the complication and symptoms are. So whether you have, and we'll talk about the coma or hepatic encephalopathy and coagulopathy, but these patients can, a lot of time comes in shock. They are at some risk of some bleeding. Infections are very common. We'll talk about how common they are and how do you follow that. And renal failure is also very common in these patients. This is the data which Dr. Superi has mentioned as part of our acute liver failure study group from 1998 to 2017. This was the last updated from January 2017 when we have close to 2,500 patients or 2,400 patients. So in America, it's iatrogenic. It's patients who are using paracetamol or acetaminophen. We don't have any restriction how much you can buy. There are stores you can buy like 1,000 tablets of acetaminophen. It's very easy, it's very cheap, and most of the cases are suicidal attempt, but also we are seeing what we call therapeutic misadventures in America. That patients are giving narcotics. It's a very common problem with has paracetamol or acetaminophen in it, and top of it, they also take a lot of acetaminophen. So about half of our cases in the United States every year is related to acetaminophen, no matter how much education we do. If you look at the other causes like hepatitis A, and we don't see like hepatitis B is also rare, and we don't see hepatitis E, which you have been. And there are a lot of other drugs that we have talked about different countries have. We mostly see antibiotic related acute liver failure, and a lot of patients also take some supplements, which are also very common. Now, this is a very nice review article which was in New England Medical Journal that they looked at it, but the bottom line you already know that in the Western world, acetaminophen or paracetamol is the major, and in this part of the world is viral hepatitis. And depending on which viral hepatitis, hepatitis B or hepatitis E is one thing. I was just listening to one of the presentation for hepatitis E in pregnancy and acute liver failure. I was shocked at how many of these women passed away, and it's like very surprise, also very sad for us. So therefore, hopefully we can talk about the management a little bit. But when you look at the clinical feature, as I mentioned early, these patients are one of the sickest patients, and there are a lot of things. They can multi-organ failure can happen. So in lungs, you can have acute liver lung injury and ARDS. So liver is very important, like as compared to a lot of cirrhotic patients, but these patients, their gluconeogenesis is affected. So hypoglycemia is such common in these that we have finger stick blood sugar and they are on dextrose strip. Then they cannot clear their lactate like any chronic, and they are in lactic acidosis. And as compared to chronic liver disease patient where their brain is used to ammonia load and astrocyte, these patients were normal and their livers only fail, their brain-brain barrier is not used to, and they pass this ammonia, and cerebral edema is one of the common causes of death in these patients, and how we monitor and manage it is very important. And obviously they have coagulopathy. In viral infection and autoimmune, you can have bone marrow suppression. It's commonly their platelet count is low and someone think, oh, they have cirrhosis, but they don't have. And same with what Dr. Superi has mentioned, that ultrasound can look like very nodular liver, but it's more because of necrosis and collapse of the liver. So it doesn't mean that they have cirrhosis of the liver. Now, as compared to hepatic encephalopathy, cerebral edema and herniation and intracranial hypertension is very closely monitored. All these patients with acute liver failure in America are admitted to the ICU. And also, interestingly, based on our data, 40 to 50% of these patients at least have biochemical evidence of pancreatitis. And so we don't know the exact, especially with acetaminophen or paracetamol, we see pancreatitis. And obviously, acute kidney injury is also common because the toxin for acetaminophen or paracetamol not only cause liver damage, but also cause ATN and kidney damage. And it's very unlikely. I have a patient with paracetamol or acetaminophen who has acute liver failure in the ICU, intubated, has normal kidneys. Because if the kidneys are normal, I'm thinking about there's something wrong, because majority of the time they will have acute kidney injury. So when you look at the outcome, this is based on our data, that there are three things we look at it. Whether patients can have spontaneous survival, meaning they will recover on their own, or about which patients. So we say like half of the patient recover without needing a transplant, 1/3 in America will need a transplant, and 1/3 die. And so the overall survival is about 70%. Now prognosis, first of all, the important thing about prognosis is depend upon the etiology. What is the cause of your acute liver failure? So as compared to the four common things we see, which is, I think this is American. So paracetamol, hepatitis A, ischemia, and acute fatty liver has very good prognosis if you manage them well, as compared to hepatitis B and autoimmune hepatitis drug-induced, or if you don't know the cause of acute liver failure. Now, the patient I presented has hepatitis B. So we look into that, at least based on our data, it considered in the poor prognosis category. Now, the second thing which is important determining how these patients will gonna do is what is their coma grade is, because that will gonna define, beside the etiology, how sick they are with hepatic encephalopathy when they came in. Because the same data, and again, this is for trainees and you already know, so in most of our studies with acute liver or grade of hepatic encephalopathy, we say early encephalopathy, which is grade 1 or 2, or severe, which is grade 3 to 4. So that's the studies have been done. So same data I showed about based on the prognosis. Now this is based on prognosis, is based on the coma grade. So same etiology with acute, with paracetamol or acetaminophen, which we call, that now that if you have grade 3 or 4 hepatic encephalopathy, your prognosis is half as is compared if you come in with early, whether you take hepatitis A. So the point is that if these patient comes late and they already develop severe hepatic encephalopathy, their survival will be poor. And these are the factors we do take into consideration when we talk about liver transplantation in these patients. Now, there are a lot of other criteria out there, prognostic indicator. You hear about King's College criteria, which is established now for a couple of decades. We also, part of our network, we had this acute liver failure study model group, which is present online and you can download it. But the point is that which patient will need a transplant. I'm not going to go into it because there's a talk on transplantation. But let's talk about in the second half of my talk about how do you manage these patients. Now these patient is in your hospital. And the first important thing which we have seen even in America, that patient come in and no one diagnosed that they have acute liver failure. They had pain and come in with elevated liver enzyme. No one checked their INR. Sometimes patient have been taken to the operating room for gallbladder surgery and came out and was all encephalopathic, or they went to the ERCP and then come in like patient's not getting better. And then someone checked the labs and then someone examined. So you need to have a high level of suspicion that, and you have to consider it. ICU management is very critical because these patients will gonna rapidly progress into multi-organ failure. And a lot of these patients, the only effective treatment will be liver transplant. And I think that's where you have to at least talk to the transplant hepatologist or transplant center, because unlike in America where you can easily transfer patients, these are not facilities available in Pakistan. So at least, but you need to, in America, you have to at least write in the note whether you talk to a transplant center, whether you consider it and why. Because if a young person die with acute liver failure and you haven't talked about it, it's a legal problem in America. We don't transfuse just because their INR is elevated. We intubate if they have grade 2 or 3, and some people say grade 3, but we have a low threshold of intubating them, and I'll show you the data that they also help with their cerebral edema and herniation, and there is no substitute for experience. Now, there was, Dr. Superi did mention about acetaminophen or paracetamol, and we use N-acetylcysteine, or we call mucomis. And this is very an antidote for paracetamol. But there was a study done by our group. It was an older study in 2009. We used N-acetylcysteine in patients with does not have acetaminophen, and the overall survival was not significantly different. But the point of the study, which has shown, and that's why we use N-acetylcysteine or mucomis in any patient with acute liver failure, that if the patient comes in with early hepatic encephalopathy grade 1 or 2 and you start them, there is a benefit towards it. The bottom line is that if you have a patient with acute liver failure, if you have availability, we use IV and you use it and consider it based on this data. Now, these are some of the specific therapies that are available, but most of the time, and depending on the severity, patient already had severe hepatic encephalopathy, anything, even where hepatitis B, it's already too late. And we have, sometimes they would not recover, but these are some of the things. But the important thing at least in America, there's a lot of board question that, for any pregnant woman who are coming in with acute fatty liver or pregnancy or anything, delivery is the answer. Because unlike in any other condition or hepatitis E, these patients will gonna recover, so you have to consider it very closely. So there are some supportive care that we talked about it is use N-acetylcysteine or NAC that we call for every patient. We'll discuss about using renal replacement therapy. There is data out there and we use very commonly in America with acute liver failure. We monitor intracranial prevention and treatment. Prophylactic antibiotic we'll discuss about what the role in, but also some of these patients have regeneration of the liver, so phosphate repletion becomes important. And hypoglycemia is so common that we use dextrose, and you start feeding early on with enteral feeding. Don't keep them like malnourished or everything. As Dr. Superi has mentioned that you need these patients in the ICU and you need a lot of specialist help, right? So the first thing, again, I keep bringing up that you need to identify those patients that will need a transplant or candidate transplant you can consider. Then you have to monitor their cardiovascular monitoring. If they are hypotensive, the vasopressor of choice is normally norepinephrine. Infections are common causes of death, so you need to have it. At UCSF, we do use prophylactic antibiotic, although data is not present there. You need to monitor their fluid management and acute kidney injury. And then we'll talk about some of the coagulation thing. So intracranial hypertension, or we call cerebral edema, based on how severe your hepatic encephalopathy. In patients who have grade 4 hepatic encephalopathy, it can be seen in 2/3 of the patient. And overall, when we looked at the studies, about 1/3 of the patient in acute liver failure basically died from cerebral edema intracranial. There are certain risk factors since we see patient with paracetamol or acetaminophen, it's hyperacute cases, so we see more cerebral edema in the US. If you're younger age, you have renal impairment or need for itonic, and the other factor is that arterial ammonia of greater than 200 is a prognostic indicator, and that points towards cerebral edema. There are some studies that shows that majority of patients who develop cerebral edema had an arterial ammonia of greater than 200. This is a patient, when I became an attending, this patient came to us, young guy who was using some muscle bodybuilding supplement. We listed them right away within 24 hours. He was listed. There was an offer for liver transplantation. We were doing everything possible. And on the way, we wanted to, and his neurological status changed. You don't need to be a radiologist. See that from the admission had CT or 48 hours that had no, and then we had an offer, and unfortunately this patient passed away. So in fact, after doing everything, there are patients who can still progress. So intracranial hypertension management, their prevention and treatment, and the prevention is fluid management is very important because we want them to be intravascularly dry. Extra fluid you'll give that patient, it's going to go into the brain. They will going to increase the cerebral perfusion fracture. You minimize stimulation and you keep the head of the bed at 30 degrees. Some patients, if they are, you can use permissive hypothermia. And then in severe cases, when they do develop, and there's a whole thing, I'm not going to go whether you need intracranial monitoring. We don't do it. At UCSF in our center, we treat every patient who is intubated as they have intracranial hypertension. We are more aggressive. We keep them serum osmol greater than 300. And then that's why we use mannitol, we use hypertonic saline. Propofol actually decreased intracranial hypertension and also has, so we use propofol. And in very severe cases, we have used barbiturated coma. Now, coagulopathy is, despite how elevated their INR, is that it clinically significant bleeding, we don't see it in acute liver failure. So we don't transfuse based on INR alone, and we don't correct that unless you're doing an invasive procedure. And there are now new technologies that are available that you can use about the risk and whether cirrhosis or acute liver failure. And so there are some, Wall-Williams factor has been associated with poor outcome with bleeding. Infections are very common in these patients, up to 80% and 40% causes of death. And the common infection we have, at least in America, staph, strep, and GNRs. UTIs or bloodstream infection, the BSI, are also very common. We used to see a lot of fungal infection when these patients were intubated and, the liver is not working. We didn't have an offer for transplantation for 4 or 5 days. We see less now, but that is still a huge concern, fungal infection in these. So the recommendation from the guideline and expert that you do routine monitoring via blood tests in patient. So prophylactic antibiotic have not shown survival benefit overall, but then if you develop a bloodstream infection, your 21-day mortality is very high. At UCSF, we use moxifloxacin based on our data that we have it, although again, a lot of sites do not use prophylactic antibiotic, that's okay, but if you want to follow them with the blood cultures and make sure start treatment. Now, if someone has acute kidney injury or renal dysfunction, their prognosis is already poor. And it happened in about 40 to 80% patient with acute liver failure. The risk is obviously if you are older age, if you have paracetamol or APAP, if you come in with infection or sepsis or SIRS. So renal replacement therapy, which we call continuous renal replacement therapy, CRT, is common in our centers. We use this a lot. It has several benefits. It can temperature control, so hypothermia we talked about. It can take away the ammonia level, so it can cause improvement in hyperammonemia. So sodium balance, we can keep the sodium and removal of some of the pro-inflammatory. So in our studies, that 30% of patients were on this renal replacement therapy. And although there were no prospective studies that have shown survival, but patients who were on it, the trend towards survival was there. Lastly, the hemodynamics. These patients have systemic vasodilation with reduced effective. So early on, you can use crystalloid, but you make sure that you just do it if you think that they are. But lactic acid is not a reliable measure of resuscitation. And if you wanted to use a vasopressor, norepinephrine is recommended more than. And there is some suggestion, although this data is not very great, you keep the mean arterial pressure of greater than 75. But because if your arterial pressure is better, your cerebral perfusion pressure is more. So, but then it's also, and sometimes hydrocortisone can be, but again, it's not shown benefit. So in summary, the important thing is that patients should be in the ICU. It does require specialty care. And you need to at least keep mentioning whether these patients need to be going to the transplant center or not. Transplant center, despite everything, is still a very centerpiece. The etiology, why patient has acute liver failure and what is their hepatic encephalopathy or coma grade, are still the very important prognostic indicator how these patients will going to do. Cerebral edema infection are still the common causes of death in this population. And supportive care, use N-acetylcysteine if we have, at least in America. We start early renal replacement therapy, and then we prevent or manage intracranial hypertension, which are very critical to the survivor. I wanted to acknowledge, Professor Roger William, who passed away a few years back, was the pioneer in acute liver failure at King's College and had a lot of, so he is one of the reasons that we learned a lot, and a lot of us who got interested in acute liver failure because of the work. And this was our study network, and thank you, everyone.
It was Professor Bilal, simple and brief as always. I will say you did justification to the topic.